Pneumonia is the leading cause of infectious death in children under 5 years of age worldwide. Now, what can be done? Is there something that we should be doing? Is there something we can do to prevent it? Learn more about this today here at Medicamp. I am your host, Mumbi Mavuti, and with me is Dr. Patrick from Kereni Mission Hospital. You're going to be learning together, so sit back, don't touch that button. Karibu sana daktari.
Sure, thank you so much. I'm grateful to be here.
Yeah, just take a moment. Tell us more about yourself.
Okay.
Yeah, your camera is right there.
My name is Dr. Patrick Angila. I'm a medical officer at Kereni Mission Hospital. I think that's all I could say at this point. Yeah.
Yeah, we are happy to have you here.
Sure. I'm glad to.
So pneumonia, it's affecting mostly our children and of course even adults and other people.
Sure.
So just start with enlightening us. What is pneumonia?
All right. So by definition, pneumonia is an inflammation of the lung tissue. I know that's how it has to come out in the initial end, but I would liken an inflammation to the same thing that happens when your skin touches an iron box. You know, so there's a way your skin is left. So that essentially is what we call an inflammation. So when such an injury occurs inside the lung, then it's pneumonia. So as we go ahead, we will discuss various causes, or rather the various forms of injuries the lung can get. But essentially pneumonia is an injury of the lung tissue. Yes.
And it will only affect the lungs. That's the only organ that it's going to affect?
Primarily, yes. And maybe I would further expound a bit. Primarily, yes, it will affect the lungs, but the complications can be widespread. And the way I would like to look at it is the lung has three major components. The first is the clothing. So the lung has like a casing around it. The second component is the tunnels through which air passes. You know, the lung functions for breathing. So there are pipes throughout the lung tissue. So that's the second component. The third component is the material itself. You know, the lung material, tunyamatwake. Yes, so an inflammation of the tissue is pneumonia. So as we go along, we'll discuss the complications, which can be within the lung or outside.
Yeah, we'll do that. But before we get to complications,
Sure.
What causes pneumonia?
Yeah, so as we mentioned, the injury can be from various sources. And classifying pneumonia has actually been quite an issue. The guidelines globally keep changing. But I think what is commonly used now is classification by cause. So, for instance, we have the most common is an infectious cause, which is where we talk about organisms or microorganisms infecting the lung. Again, that is further subdivided into various classes of organisms. But on the broader end, we say we have infectious causes of pneumonia and chemical causes of pneumonia. Like I was saying, the infectious causes are the microorganisms, virus, fungi, as well as bacteria. The chemical causes are not as common, but commonly happens when we inhale. For instance, you're taking a glass of tea, and then instead of going to the esophagus, the tea goes into the lung tissue. That will still injure the tissue, and that is also a form of pneumonia. We call it chemical pneumonia or aspiration pneumonia. Sure.
Now you've talked about viruses, bacteria, and also the food particles.
Yeah.
Most of us were hoping to hear pneumonia is caused by baridi, You'll hear people saying, va vizuri, utapata pneumonia. Doesn't cold cause pneumonia?
No. Cold does not directly cause pneumonia. However, it's an associated factor. Just like we'll discuss other associated factors like age, So, but the way cold is associated with pneumonia is cold temperatures are associated with a reduced body immunity. Especially for parts of the body that directly communicate to the external. For instance, the kidney is hidden, it's not as openly exposed, but the lungs we have the nose, which is open to the environment. Then it's a complete open tunnel all the way to the lung. So whatever is happening in an immediate environment can go in. So part of that is cold. So when our airways are exposed to cold, it sort of impairs our immunity, our first line immunity. And that is somehow why a lot of people, or rather many people in colder environments, might be prone to pneumonia, but cold is not a direct cause of pneumonia. Yes.
Thank you so much. That is a lot of education for most of us.
sorry. But that's
Yeah.
why you're here.
Yeah. And is it also can cold also become a factor in this manner that it's going to create an environment that is going to harbor the growth of viruses and bacteria?
Definitely. A lot of, especially bacteria, a lot of them survive, or rather thrive, in cold environments. Not extreme cold, but a certain degree of cold environment, which again is the same thing. So exposure to cold environment makes our airways cold, and that is where our immunity lies. So while you're impacting the immunity, then the bacteria are free to, have their way. Yes.
Thank you so much, Doc. And who is at risk? Mostly, like I stated while we were starting, children are the most affected.
Sure.
Is age a factor?
Yes. Probably we can then talk about risk factors for pneumonia. Like we are saying, going from slightly back, we had, broadly classified pneumonia as caused by commonly bacteria, top of the list. Second to that are viruses, especially children. And then third to that are fungi, which happen mostly when people are immunocompromised, people who have other conditions that reduce their immunity. The other extreme is what we call chemical pneumonia. So when we talk about causes, then we have to start from that point. So bacterial causes of pneumonia, or rather risk factors that are exposed to bacterial pneumonia, one is what we would call extremes of age, either too young or too old. It's unlikely, or rather it's rare to find pneumonia in the middle-aged group, like a 35-year-old male. So infants and children, and then the older groups, those are like 3 risk factors. The other risk factor associated with pneumonia is chronic lung diseases. So people who already have some lung disease are more prone to developing pneumonia. Like we mentioned, immunosuppression. So if an individual has diabetes, has some form of cancer, not necessarily lung cancer, cancers anywhere, some people who have maybe HIV, AIDS. So generally their immune system is a bit suppressed, so they can quickly pick pneumonia. Yeah.
And what about people who smoke? The moment you're smoking, it's going straight to your lungs. Is that going to...
Definitely smoking will predispose you to pneumonia, but only at a point, after it causes you some lung disease. So we categorize that as people with lung diseases, but definitely smoking is a predisposition. Yeah.
Thank you for that, Dr. And what are some of the signs and symptoms, like how will someone know they have pneumonia, or maybe they're developing pneumonia?
Okay. So in the study of pneumonia, I hope we don't go to the extreme, the really big end, but let me just try to make
it as much as possible.
Exactly. In the development of pneumonia, what we call pathogenesis, from the onset of the bacterial infection, everything that happens to the point, whatever outcome. So first, whatever cause enters the lung, be it a bacteria, be it a virus, a fungus, or even a chemical, enters the lung, then inflames the membranes of the lung tissue. So that, therefore, causes, when the body naturally perceives an invasion or an attack, the body responds by increasing blood supply to that place. So the blood that is increasingly supplied has a lot more of antibodies, a lot more of our defensive cells. So that, therefore, means the lung gets a bit congested at the very first end. So that is how the symptomatology will come. So first of all, having been, having the lung having received a lot of blood, it's a bit heavier than it would be initially, and then that's the first step. Then the second step is when the body cells encounter the bacteria or virus of whatever sort. So usually it's kind of a tug of war, and the product of it is some sludge, some sort of like, both of them are damaged, then they form some fluid, sometimes even pus. So that is at a point. Then afterward, that complex that is formed resolved over a few days, like 7 days or so. So that is really where the symptoms come from. So I would say, for instance, at the stage where the lung gets a bit congested, at the point where the infection has taken place, people will feel a bit breathless, because your membranes, which are supposed to sustain your breathing, they are inflamed, so they do not do that function. So the body perceives a reduced oxygen supply. So people will feel breathless. An infection, bacteria, viral, whatever cause, will again cause, like I said, the body cells coming to defend us. That reaction usually makes the body hot, so we get fevers, because it's the product of that tug of war is some form of fever. So people will feel febrile. I said the cells, when they engage and then form a complex, people will feel like they have a cough. That complex of fluid might present like a cough. So you'll hear people trying to cough and sometimes actually coughing sputum. So sputum is actually a combination of the infecting or the invading organism and the body cells that sort of fight and engage together. So other than the cough, people will have breathlessness. I mean, the chest might be heavy. People might be struggling to breathe. You walk a short distance and you feel like your chest is heavy. Other than that, they can vomit as a symptom of the infection spreading through the body, and that can cause some vomiting. I think generally that is largely what happens. Yeah.
Thank you so much.
And chest pain, of course, because of that, yes.
And when you're talking about chest pain, is it likely that this person is going to feel fatigued or tired most of the time because of pneumonia?
If we go that direction, then we might get a mix-up, because pneumonia doesn't have to really keep you fatigued. Because the good thing is, rarely do you have pneumonia affecting all parts of the lung. The lung is subdivided into lobes. So there's an upper lobe, middle lobe, and the lower lobe. So rarely do you have all the lobes affected, although there are times when you have that. So usually, when one lobe is affected, all that process takes part in that affected lobe, therefore leaving all the other parts to compensate. So pneumonia will rarely give you, unless it's very severe. In very severe forms in adults, people will be fatigued and etc. Although that will be more towards cardiac disease and something. Yes.
So not exactly communicating of pneumonia.
Yes, but in children will present with irritability. They will cry, especially because of the fever. So there will be children that are crying, and then you can have a bit of some form of noisy breathing, and then on top of that, they refuse to feed for children. Just like in adults, you might have poor appetite because of the infection that's going on. Yes.
Thank you so much for enlightening us. So we've talked about the signs and the symptoms, but you're mentioning there are types of pneumonia.
Yeah.
Like we've told us there would be pneumonia that is caused by bacteria and another one caused by a virus. So what is the difference between these types of pneumonia?
So the difference is, just as you mentioned, in the causative agents. So pneumonia can be caused by, and that is really specifically under the infectious pneumonia. So we can have bacterial causes, like you mentioned, then viral causes and fungal causes. So bacterial causes are the most common. And this means they are caused by bacteria. Bacteria, I don't know what I would say to differentiate bacteria from viruses in terms of description. But all of them are microorganisms, in our environment. Bacteria are more common than viruses. But so in terms of causes and in terms of classifying pneumonia, under bacterial pneumonia itself, we have certain bacteria that are more likely to cause pneumonia, given their abundance in our immediate environment and the state of the body defense. So for instance, or rather, we have bacterial pneumonia classified as typical pneumonia or atypical pneumonia. So the typical pneumonia, by the word, it's like what we expect. It's like the thing that does not surprise us, typically. Yeah. So typical pneumonia is caused by typical bacteria, and these are bacteria that are more common in our environment, like Staphylococcus aureus, even present on our skin. The atypical type is caused by bacteria that are not typical. The difference between typical and atypical bacteria might be a bit scientific, but essentially it's just in the morphology of the bacteria. So typical bacteria have a cell wall.
But maybe to just get it straight, the atypical one, the atypical bacteria, that would cause a more severe form of pneumonia?
Yes, I would say so, especially because their treatment might have to involve stronger drugs. Yes. So typical pneumonia, they are more abundant bacteria, more common bacteria, and then that makes them easily treated. They are easy targets, because they have that cell wall. So the way antibiotics work is they enclose, they become part of the wall around the bacteria, so that as the bacteria tries to replicate and increase in numbers and grow, then the drug has planted itself, so that kills the bacteria. So that is the advantage of having, rather the advantage of the benefit of typical bacteria. The atypical bacteria do not have that cell wall, so attacking them by drugs is a bit more complex, and so that's why if you were to treat an atypical pneumonia, you would not use your first-line antibiotics like the penicillin, because the attack on the bacteria will be a bit more, you require a bit more intense, an intense approach. Yes.
Another type of pneumonia that we've had is mycoplasma.
Yes, which is actually bacterial in cause, but of the atypical end.
Oh.
Yes.
And I also mentioned something as aspirational pneumonia.
Yes. Before you talk about that, allow me to talk about the fungal pneumonia, because we've done actually viral and fungal. We've talked about bacterial pneumonia. Let's talk about viral pneumonia. This is common among children, especially. So I think what the commonest we've had, the one that we'll all relate with, is the COVID-19 pneumonia. That was
COVID-19 was a pneumonia?
Yes. COVID-19 was a form of pneumonia. So the virus would, enter the airway and blah, 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 and cause complications both in the lung and far distant. So that is a form of viral pneumonia. The other form of viral pneumonias are influenzas, like in children. So you have children who have what looks like rhinitis, runny nose, etc. Then over time they develop some cough and a wet chest, etc. So that's also possible. Unfortunately, viral pneumonia does not have what we call, an absolute form of treatment. There's no one drug you say, give this and it'll clear viruses. No. So what you do, rather maybe we'll discuss that later, but the thing with viral pneumonia is just do supportive care. Let the patient come for it. If they're not breathing, give oxygen. If they're in pain, give a painkiller. If they have fevers, just so that you limit, you don't give antibiotics when it's not necessary. And that's what a lot of people do, which again is contributing to what we call bacterial resistance, which is a big, huge topic going on. Yes.
You mentioned that this viral pneumonia, it's common in
children and let me say extremes of age, but in our setup, a lot more children than adults.
Why do you think it's that? Because it's also causing a lot of deaths in children, even in our country.
Exactly. Allow me pick it from this angle. Although viral pneumonias are common in children, they are not the majority among children pneumonia. So if you were to get children with pneumonia, most of them will be bacterial. A few of them will be viral. So if we talk about mortality, the number of deaths of children, the number of children we lose to pneumonia, majority of them will actually be because of the bacterial cause. And the reason for that high number is not because we don't have the drugs, and it's not because maybe the children are extremely, sick or something. It's just that I think it's in our healthcare system, because you receive mothers who, for instance, present to the hospital late. I would suppose if, like I was trying to say earlier, there are phases of pneumonia. There's the congestive phase, there's the phase where a lot of other things happen, the red hepatization, to the point it resolves. So it depends all along that course of development. When does your patient present? If it's an adult, you have the chance to try here and there. But for children, sometimes mothers present late, especially because they do not know the signs. The child could just be crying, refusing to feed, and their body is hot. They go to pharmacies and they get ibuprofen, etc., which does not treat the pneumonia. Then the pneumonia spreads, gets into the blood, they get sepsis and septic shock, and then their lives are cut short. So I would attribute the high number of deaths to our health-seeking behavior, because I would not say we don't have drugs. We do. So I feel like we present to the hospital late. Yes.
Thank you so much for that, and thank God we are here with you, and we're here on Medicom.
Sure.
I'm sure they're getting that message.
True.
Our parents back at home, they're getting that message. So let's move on to mycoplasma pneumonia. What is it? It sounds complicated.
No, mycoplasma. Is it as complicated as Haemophilus influenza? So it's just mycoplasma pneumonia. Mycoplasma is a bacteria, just like Staphylococcus aureus or Haemophilus influenza or you know, so it's by name. The name could sound complicated, but that's just an organism, that's one of the organisms that cause pneumonia. And like we said, it's one of the bacteria. So discussing bacterial pneumonia, we have the atypical, typical, they all lie there, with mycoplasma being on the atypical end. So really nothing interesting. It's just an atypical organism that causes pneumonia. And like we were saying, rarely happens, but when it happens, difficult to treat. Yes.
So you also mentioned about the aspirational pneumonia,
Yes, yes.
where the food particles or something that is not supposed to
go there.
go to the lungs. Because how does that happen? Given that, you know, I assume if I take water, my body
Should
knows that
control
it automatically take it to my stomach. How does that happen?
Okay, again, let me hold you back a bit before we talk about. Let's just finish up on a fungal pneumonia. Fungal pneumonia, very quickly. Fungi are other forms of organisms in an immediate environment, and like we were saying, fungal pneumonia commonly affects people with immunosuppression. I think the most common are people with HIV/AIDS, where we have a form of fungus called PCP. Right? PCP is it's a long name. Giroveshi pneumonia or something. Yeah, so that is the commonest. But essentially, let's look at it this way: if a patient, you know, for whatever reason has HIV/AIDS at the very advanced stages, and then they present to the clinic or to the hospital with a chronic cough, and then you've ruled out TB and you've ruled out a heart disease, you know, you rule out any other possible causes of such a cough, then by exclusion you have a fungal pneumonia. There are other tests that can confirm if it's fungal, but unfortunately I think the last time I had, they're quite costly, and some of them are not in the country. So we do that by exclusion. But most importantly, so fungal pneumonia is commonly amongst people with severe immunosuppression. So that concludes the infectious causes of pneumonia, and then we can rush to the other end that you're really concerned about.
Yeah, I'm really so concerned with that.
So aspiration pneumonia. So aspiration pneumonia, like you're saying, it's aspiration. So means food content or whatever. You know, might not be food content, might be something someone forced through your mouth. But the whole problem is it does not go through the food tract, and instead goes into the trachea, which is the air or the windpipe. So anything other than air that goes through the windpipe will irritate the lung, and that will cause some form of injury, and that is classified as aspiration pneumonia, and maybe chemical pneumonia as well. So this is why it happens. We know very well that our swallowing process is coordinated autonomically. So you can eat, then you know the body has a way to close the airway so that food goes to the food pathway. So when that process is hampered for whatever reason, and we can talk about the reasons, so that you eat, but instead of, you know, the epiglottis is closing, it stays relaxed, so food goes whichever way, then we can have that. It might be important to mention that aspiration pneumonia commonly occurs in people whose GCS, or rather people whose cognitive function is a bit suppressed. So for instance, you have patients who maybe have had a stroke, they're a bit confused and unconscious, they cannot cough. You know, like if you are taking your water and then you choked mistakenly, you would cough to clear your airway. So anyone who does not have that cough reflex, maybe they're unconscious or they have any disease of that part of the body, which would prevent food going the correct way and air going the correct way, they would develop aspiration pneumonia. I would like to speak about a common, rather a special group of people, not by discrimination, but because especially in adults, they are the commonest we find with this. And these are alcoholics. So I'll tell you about a patient I have seen, and a patient who tried, you know, people struggle with alcohol use or rather addiction. So he's a gentleman who had struggled with alcohol use and for some time, I think like 2 years or something. And then a friend flew into the country. The friend had been living outside the country, so a friend flew and like, hey bro, let's go and catch up. And I think out of the excitement of catching up, they went out on a drinking spree. So this time he drinks. Having stayed long, you know, he really did a lot of it. And then comes to the hospital the next day, drunk, with very poor air entry. You know, as you examine, you realize that one side of the lung really is not taking in any air. So that is commonly what happens. That group of friends, people who drink a lot, they have a bit of that issue. So that instead of, you know, air being coordinated to go the correct path and whatever liquid or food they take goes the other way, it can happen whichever the way. So drinking is, I think, one of the commonest I have seen in my practice to really predispose people to aspiration pneumonia. Children, especially those that have GAE, I think GAE is adenotonsillar hypertrophy, adenoids behind the nose, and then tonsils. They also get recurrent infections, and because of inflammation going on around there, like we were saying, inflamed tissue does not work well. With inflammation, you lose your function. So if you inflame the epiglottis, then its role of, you know, flapping to close the windpipe is a bit compromised. So they'll have inhalational injuries, which will cause chemical pneumonia or rather aspiration pneumonia. Yes.
So we'll revisit that when we're talking about treatment.
Exactly.
Because again, we're curious.
Yes.
But right now, let's talk about complications associated with pneumonia. Because you're mentioning that someone will struggle to breathe, and I'm sure that is going to result to some complications.
Exactly. So in terms of complications of pneumonia, I would like to classify them into two. Localized complications and distant complications. So localized is to mean the lung. So within the lung, your lung is injured, your breathing is a bit impaired. What happens? In severe cases or extreme ends, people may totally be oxygen dependent. So you find someone who has pneumonia in a severe form who cannot breathe on their own. So they start getting hypoxia. Hypoxia is a situation where your oxygenation is not adequate to, you know, give your blood adequate oxygen for all the tissues of the blood. So with hypoxia, at the very extreme end, if you're not oxygenating your blood, critical organs like your brain gets a bit of injury because they're not getting adequate oxygen. But that's very extreme. So, well, let me just summarize it this way. One of the complications is the lack of, you know, oxygen dependence. Oxygen, you can't breathe on your own, so you need oxygen. Secondly, is the other localized way I would look at it is what we call pleural effusion. And I would take us back to what we were talking about earlier. I said the lung has three components, and one of the ones I mentioned was the closing of the lung. So between the lung tissue itself and the closing, there's a bit of a space. So usually, depending on the location of the pneumonia, so that can sometimes lead to fluid accumulation between the lungs and the clothes. And the fluid can be massive, can be little or a lot. So that is called pleural effusion. As it builds up, it further presses the lung, and your breathing is further impaired. So other than that, we can have the bacterial agents themselves. Other than being in the lung, they can get into the blood. Then the blood, you know, as it circulates, so the infective components of the bacteria, the toxins, are circulated all around. And that's what we would call the part of the distant complications. That is sepsis or septicemia. That would further maybe lead to what we call septic shock. So you have sepsis in your body is overwhelmed, you know, your system starts shutting down, your kidneys, your intestines, everything shuts down. And that would be called septic shock. Other than that, pneumonia can also give you rather, especially if recurrent, it can lead to some form of chronic lung conditions, you know, because you get it today, you heal, you get it, you heal. So that can lead to some fibrous changes in the lung that might be long term. Other than that, I think mostly that's all. Perhaps, yeah.
Yeah, and pneumonia can be cured, right?
Yes. Yes.
What would make it recurrent in that case? Because you get treated. And
then you get it again. That depends on why you got it in the first place. So if your risk factor is recurrent, for instance, if you have immunosuppression, for instance, malignancy patient, cancer, or HIV/AIDS, you get pneumonia today, there's a chance you can get it again because the problem is that your immunity cannot stand. Maybe the younger age group or the adults, that can also happen. The other form we get is patients in hospital who have patients who are intubated. I think maybe we should have mentioned it along the way, but there are patients who cannot breathe on their own, and as such, we intubate, and then we have machines breathing for them, ventilator machines. So there's also a form of pneumonia associated with ventilation. So the objects inserted in the airway can also sometimes result in some form of pneumonia. So like in such a case, if you are still on ventilation, I will treat you today. I do a full course of treatment for a week or so, then it resolves. But for as long as you're still on the ventilator, you can get it again. So essentially, we're just saying, as long as your risk factor is still present, there's a chance you can get it again and again. Yes.
Thank you so much, Dr. We're going to be taking a short, quick break, and we're going to be right back. Thank you so much for you who has been tuning in from the start of this. Stay tuned, don't go away.
Thank you.
We murutana ni warikire kirathi gia form 4 ndugatangike ringi gwakinya ni thukuru wa guthomera kothi ya wendi waku. The Abadia Technical College Karatina mariha ni undu waku marakumenyithia oyani wa general intake ni urathi na mbere na mathomithagia kothi nguhi ta hospitality management kana catering, hairdressing and beauty, videography, photography, computer studies, driving school na ho ICDL. Gwakinya ni rungiriru wa mathomo ndukange nganje na ithwe kuona twandikithitio ni ruhonge rwa TVET na arutwo aitu tumateithagirie kwigwatia attachment na kuri arutwo aitu akuraihu ni ndu wa gukoma turi na hostels kohoro makeria tucere thukuru na itu mwena wa Karatina mita 500 kuma barabara-inĩ ya Karatina guthi Nairobi kung'ethana na Brookfield Academy kana utware kura thimu namba 0726 507 444 kana rurenda rwitũ nĩ ruo www.aim.ac.ke. The Abadia Technical College Karatina, aiming beyond the ranges. Kwigwatira Musa kurira kwa jithero ro Andy Wawa featuring Elizabeth Nyambere taskiza tuni ya thimu yaku hihinya *837 *3260# okenagie hari marakurira thimu na rugambi ruru.
Thank you so much for staying tuned in. Welcome back. And in case you're just joining us, we're talking about pneumonia. We have learned quite a lot about the signs, the symptoms, which can affect, what causes it. And right now we are talking about treatment. We had started a little bit on treatment, but what treatment options are there for patients with pneumonia?
All right. I think at a point we mentioned a cause of the development of the disease and the point where the patient comes. So that matters. But essentially, of course, we know one of the ways to treat is to treat or give a drug that will kill the cause. That is the definitive treatment. So if it's a bacterial pneumonia, we'll start you on some form of antibiotics. But that is as good as the bacteria is concerned. There are different patients, and especially in their stage of presentation. For instance, if I received a patient presenting who cannot walk and who cannot breathe, so part of my treatment is actually oxygen. We in the medical space we consider oxygen as a drug, which is prescribed. So other than the definitive treatment of pneumonia, I also need to treat every other concern that the patient has. If a patient has fevers, hotness of body, I need to give a drug that will tone that down a bit. So that's part of the treatment. So I can give, in our space, I think paracetamol or ibuprofen is one of the commonest we use. Because the fevers, again, like you're saying, like we earlier on described, so pneumonia is the disease, but the symptoms are multiple. Each of them bothering the patient in various ways. Because if a patient has fevers, they'll tend to put off their clothes. In babies, they will convulse again because of the hotness of body or fever. So as you treat the definitive cause, number one, give supportive treatment. So supportive treatment means each of the other concerns are attended to. So you can give oxygen, that's a form of treatment. You can have the patient intubated. If especially they come at a very, very advanced point where, you know, they're totally unable to breathe, you need to support their airway, you need to support their breathing. So you can actually put them on machines to breathe for them. But all this depends on the stage of presentation. However, allow me to talk about the drug treatment, or rather the drug treatment of pneumonia, because I have a problem with it. The concern, like we were saying, is, of course, we know we need to give antibiotics. And the problem is this, that most of our people feel, or rather think, they can easily and safely treat pneumonia from home. So a child might be coughing, especially the children age group, the child under 5s. So a child has some of these symptoms, and mama, with all the love and care, takes the baby to the pharmacy, and they're given some form of drugs. So this is where I have a problem, especially because I mentioned the antibacterial, the antibacterial resistant. So we have people giving antibiotics, one, when it's not necessary, two, when it's not the correct drug to give. So over time, we end up having bodies that are used to antibiotics. And we have organisms that have learned all the antibiotics we have. So they know you come from the north, they know, okay, this is how you come, I can hide. They know you come from the south in this manner, this is where I defend myself. So that is essentially one of the biggest challenges we face with treatment of pneumonia and other common infections. Doing it outside hospital in ways which, we might get it wrong. And in the long run, we have patients who develop resistance to pneumonia. And the complication with that is next time you have pneumonia, and I'm receiving you as your doctor, as your first doctor, I would assume you're a naive patient who's not had any previous exposures. So I start you on like my first line. Then, after 5 days or 3 days of treatment, you realize the patient is not responding. Then I start to adjust my drugs. So you have patients who are resistant to nearly, sometimes all available antibiotics. So that is really such a problem, because in the long run, then we keep changing the drugs we use, and that implies that even the cost of treatment changes. Because our simpler drugs cannot treat it anymore, we have to use stronger and more drugs, which implies then we spend more time in treating pneumonia, which should otherwise have been, a simple first-line antibiotic. So just to get back to where we were, treatment of pneumonia, number one, be sure to treat the cause, be it fungal, bacterial, or viral. Be sure to treat that. And then on top of that, give supportive care. If your patient needs oxygen, give it to them. Still, if your patient is not feeding because, they have loss of appetite due to the sepsis going on, give some form of food. You can give IV, IV, the kamaji that we give, the IV fluids in form of dextrose, but that cannot go for certain days. If you feel your patient is not feeding adequately, act on that, intervene. If your patient is, sweating a lot, adjust the fluids you're giving them, give them drugs to tone down their temperatures. So that is essentially what supportive care is about. If they are coughing in a way that is bothering them, you can give them drugs that tones that cough reflex a bit. So there's the definitive treatment, supportive treatment, and that is essentially what it is. Going to the other forms we mentioned, like, for instance, the aspiration pneumonia. And this, I would say, like we were talking about it earlier, we mentioned it's a unique form, somehow isolated, and sometimes the treatment gets difficult. If you aspirate and the chemicals or food or whatever you took in has gone into your lungs, usually the injury is much worse than if it were a bacteria. Assuming a whole cup of alcohol, instead of going to the stomach, it went to your lung. Other than accumulating in some pockets, it really irritates, the entire airway. So it's a much worse form of injury. And the treatment, like we say, we will definitely treat based on the cause. So, for example, in aspiration pneumonia, part of what you want to do is to reduce, or rather, control the way the body reacts to it. Like we said earlier, an invading organism is encountered by a defensive cells, like a line of defense. Then in the process they fight, and then both of them might lose. Then we form some fluid, which is whatever. So anytime the body is reacting to something, the body will perceive or tell itself, man, we're in danger. So one of the things that happens is the temperatures go high. So with aspiration pneumonia, then such a reaction is actually worse. So what you want to do is to give the body drugs that will sort of like tone down the body a bit, because you are sure it's not bacteria that will multiply. There's a certain amount of fluid that is there. So what you want to do is just support the lungs to keep the patient alive. Other than that, reduce the way the patient will react to it. So sometimes we use steroids just to tone down that reaction a bit, but most importantly, you support the lungs to breathe. And that mostly happens in ICU, where we were saying the patients are intubated, and so that even though they are not able to breathe on their own because of the extent of the damage, we are able to give them adequate oxygen by the machine until that lung heals. Then we can slowly wean them off the machine and allow the lungs to pick up and breathe on their own. So that is just one form. But essentially, to summarize, for pneumonia treatment, we have to treat the causative agent, be it an organism, be it a chemical. Number one. Number two, give supportive care when necessary. Yes.
For the supportive care, is it in extreme cases?
No. It doesn't have to be in extreme cases. Of course, for supportive care, let's look at it this way. One of the things that might happen is, for example, vomiting. Yeah, and you have pneumonia in the lung, and a bit of the microorganisms have escaped our defensive cell lines and gone into the blood, and as such, they are circulating. The body perceives that as a dangerous state, so the body reacts by ejecting things. What will most likely happen is vomiting. So if I have a patient who walks in, they are strong, they're just coughing, but they are vomiting because of the sepsis. Then part of my supportive care is to give them a drug that will stop the vomiting, so that should they feed, they are able to retain the food. So supportive care applies all through, whether non-severe or whether severe, all through there's always something to do. And part of that, like for babies, sometimes you come with the hospital, mama is told, Mami, mtoto wako na joto mtolee nguo, to just calm baby down a bit in terms of their body temperature. So that is also supportive care. So supportive care is there all through the process, just different based on the degree. Yeah.
Now I'm looking at it like a patient who is admitted in ICU.
Yes, please.
And is there a chance that the treatment, given that you talked of intubation,
Yes.
is there a chance that they could get another disease, or that could result to another complication, that kind of treatment?
I don't know if I got you right, but you're asking if treatment in ICU for a pneumonia patient can give other diseases.
Yeah, can result to another complication later.
Yes, and unfortunately, this is a state of things. The devices used in ICU are quite invasive, like the intubation, the endotracheal tube. It goes beyond your mouth, sort of like to some parts of the trachea. So that in itself is an invasive intervention. So the challenge we have, and which is expected and is scientific, is that anywhere that at any point you're doing an invasive procedure or an intervention to a patient, then you risk exposing the internal parts of the body to the external by the means of that, invading tube or whatever. Just like in theater. We go into theater, at a point you have to change your clothes and then clean everything, leave the things belonging to the outside, then dress up afresh for the inner. So that is really what happens. And like we said, there are endotracheal intubation related pneumonia. So that is really expected. I could have taken my patient into a ventilator, intubated, with maybe a Staphylococcus aureus, which is a very simple form of pneumonia. And then, given the invasiveness of that, intervention, they pick up some other form of pneumonia, which we actually call it hospital-acquired pneumonia, and whose organisms are quite resistant. I think what the most common is a methicillin-resistant Staphylococcus aureus. So these are same bacteria, but which have learned the game. They know all the drugs you can use, so they resist. Yeah, because they're in the hospital environment. So there's a chance, whether in the ward or in ICU or HDU, a patient can always pick something from hospital. Yes.
That is quite enlightening. And before we move away from treatment, it's quite good that you mentioned and warn people about self-treatment, because that could result to a lot of problems later, because we cannot really say not get sick again in future. Yeah, so when we move away from that, can we prevent pneumonia?
Yes. Pneumonia is actually preventable. I would say even naturally by our own body cell lines. And the body is designed to do so. You realize in the nostril, there's some form of hair. So that is part of cleaning the air that goes into our lungs. Along the trachea itself, or rather the windpipe, we have certain small air, not like the ones we have, very, very small, and whose role is to, behave in a manner like so. So what they do is to swipe, because the airway naturally has a bit of secretion. So that secretion is swiped forward, then the hair gets backward, and then forward. They're called cilia. So in that way, whatever dirt that might be in the lung is pushed. All right? So that's also a form of, there's a natural way the body is adapted to clear the airway, so that whatever dirt is there is brought up, and then you feel the urge to cough, and then you cough it out. Other than the natural way, we can tell people to wear jackets. Yes. I know based on the earlier question. So although pneumonia is not directly caused by cold, but in a cold weather, you can try to keep warm. Even wear masks, again, because sometimes the causes of pneumonia, like mycoplasma, the one you're talking about, the way it can leave my body to yours is by a cough and air droplets. So if you are to get a mask, then you protect your airway. So other than that, I think the most important bit I would like to talk about is actually vaccination. So there are vaccines for pneumonia. And I think our society is a bit slow on this. I would say, not just our patient population, but even our hospital population, some hospitals. And the poor practices that I was talking about at the over-the-counter drug medication. And this is the way I look at it. There are vaccinations, but we don't routinely hear about it. Although I wouldn't say everyone should get it, but it's prescribed for special groups of people, and these are people who have higher risks, rather, like we were saying, risk factors for pneumonia. I would give you examples. If you have a patient who has chronic obstructive lung disease, we call it COPD, but this is some form of damage to the lung because of cigarette use. So long-term cigarette use, then the lung gets a bit damaged here and there. So the lung itself is damaged. Even before a bacteria comes in, the lung is damaged. So patients with such condition, and which are irreversible, by the way. So that damage is never reversible. You can only stop it from progressing, but it's not reversible. So when the lung is in that state permanently, then as the doctor seeing your patient who has come with pneumonia, or rather maybe not even pneumonia, you should actually think about the lung. I mean, this is a lung that is already injured, and the lung has changed because of the disease that is already there. So as part of, and this is where some of us fail, you meet such a patient and let them go home, without telling them that, Mr. or Mrs. So-and-so, I would like you to get annual pneumococcal vaccine. The reason is because your lung already has a problem. So there's a high chance that, even your immunity, like you were explaining, the other lines that we have naturally are damaged. So any little bacteria that drops in there will give you a problem. So for people who have such conditions pre-existing, always prescribe them annual pneumococcal vaccines. I think the one we can relate with most, especially with the viewers, is a COVID pneumonia. People that have COVID, or rather who suffered COVID, had a bit of post-COVID lung changes. So you have seen some of them who are actually, on oxygen still to date at home, people who work with the oxygen cylinders, because the COVID never left the lung the same. Part of the way we are, taking care of that population of people is to prevent pneumonia. Prevent pneumonia by giving annual pneumonia vaccine. The other way the vaccine is prescribed is in people whose whose spleens are either absent or were injured, and then a surgeon had to go in and cut it off. And that is because the spleen has a protective role against certain types of bacteria called encapsulated bacteria. So if someone was hit, maybe you were assaulted, or rather you were fighting and somebody hits particularly your left side of the abdomen at this point, sometimes you injure your spleen. And based on the grade of injury, a surgeon might decide to go remove it entirely. And that means its role in immunity is gone. So those are also patients that routinely they know they have to live on vaccination against such bacteria, some of which can cause pneumonia. So to get back to what we are asking, pneumonia is actually preventable by practices like that, and most importantly, vaccination when necessary. And we should never miss those chances. Yes.
And I think the government has not really done enough to sensitize people and make them aware that there are such vaccines.
I would say yes, because clearly, like my patients, sometimes I have that conversation with them, and the relatives be like, Daktari, does he need this? Do we really need this? And what is it? Why are we giving it? So that essentially means that maybe people don't know about it as much. And then I think, other than that, most of the time, I think all the times I've seen that vaccination given, it has to be bought. So, and not cheap, not cheaply. So then it means I think our government there's that gap slightly in terms of information, other than information, in terms of the availability, especially when we have many chronic lung diseases, especially post-COVID. I would assume the vaccination should have been more rampant, because COVID never left our society the same, and people who were affected whose lungs didn't get to recover, they have to live on it. So I think that's a point we can keep doing. But as for education, I wouldn't blame it on the government. I think it's on us healthcare workers. Yes, because my patient comes with chronic obstructive lung disease, or maybe some form of very severe asthma. Then I resolve the asthma, treat it, and then when my patient is okay, I let them go home without telling them that bit. Then it's on me squarely. It's me. So I feel like in every encounter we have with the patient, let's teach our patients. And this is a practice that is really picking up in the world, and I'm glad I would say we are really doing well in the hospital I work at, Kiriani Mission Hospitals, because we have sessions where your doctor has to speak to the patient, not just about pneumonia, but about heart failure. So as we send you home after whatever treatment, what do we expect of you? Other than telling you to come back for the clinic, what are you possibly going to encounter? How do you address it? What are the worrying signs? What should you do when should you get to hospital? Even before your clinic. So that is an engagement that we should really do with our patient, because education the patient really is with us. Out here, not everyone is a patient.
Right.
But when you have a chance with the patient, never let that chance go without telling them what's necessary.
Thank you so much. That's where you're going to be wrapping it up. True. And thank you. We have learned a lot, and also unlearned that pneumonia is not exactly caused by baridi. Yeah. So,
but they are associated, yes.
Yeah. So I want to give you a moment to maybe give a shout out to anyone as we wind up.
All right, thank you. As we wind up, let me talk about something that really concerns me. Please, to all our patient populations, do not treat pneumonia over the counter. Do not take drugs before the doctor prescribes it. The reason I'm saying that is pneumonia can be simple, severe, or even with complications. If you went over the counter, when you're ready there's a complication, someone will give you drugs which you take, might sort it out, but the complication is there. So let's learn to be friends with the hospital. I think our hospitals are getting friendly. Let's learn to be friends with the hospital. Let's not treat ourselves at home. Let's not go to the pharmacist asking for drugs, especially antibiotics, to treat things we may not even know. Sometimes it's not even pneumonia. So it has to take a doctor to sit down with the patient, listen to the history, examine physically, do investigations like chest x-rays and etc., and come up with a diagnosis. And realize if there are complications, what do we do about it? So let's not miss out on all that, especially when we are able to. So I hope that really improves over time, because it reduces our disease burden. So that a patient we could easily treat in outpatient or even in the ward for 5 days, sometimes present later in the street, goes to HDU. they pay more there. So it means that the same disease, but which was picked late, is now costing a lot to treat because we took some time somewhere that wasn't necessary. So let's be friends with the hospital. And if that is improved, I think personally I'll be very happy. Other than that, you asked me to give a shout out.
Yes.
Whatever it means, but I think I'm really grateful to be here, first of all, to you guys. And I'm also grateful for my hospital, the place I work at Kirini Mission Hospital. I'm glad they've even, allowed me to be here to talk to this audience and community. And I would encourage you to visit. Yeah, because you might want to see how we attend to our patients. Clearly, it's an amazing way. So shout out to Kirini Mission Hospital, our management, and all the staff that do the beautiful job every day of taking care of our patients. It's amazing. Please visit someday. Maybe next time we can have this interview at the hospital.
Yeah,
Yes.
we'll be sure to visit.
Thank you.
So yes, don't be a self-doctor, just visit a doctor.
True.
And remember that your health is your wealth. I have been your host, Mumbi Mavuti. See you on our next episode.
Pleasure.